Hi, she is an elderly lady with phacolytic glaucoma and she is posted for surgery. She also has fluid exfoliation. The cornea is not great and she has got quite a dense arcus sinalis. A posterior subtenous injection of 1 ml of lignocaine is given. The paracentesis are made. I'm also using a bit of intracameral dilating agent along with anesthetic, hopeful that the pupil will dilate a little bit. The capsule is stained, the eye is pressurized with dispersive OVD, and the main incision is made. So as expected, the challenges in this case would be the first to get the rhexis right. Second challenge, which is probably the greatest challenge, would be to manage the freely mobile nucleus, which also would be quite dense in these eyes. Let's see how things turn out. As soon as I puncture the anticapsule, there is egress of the liquefied cortex out. I'm using my bimanual irrigation aspiration system to clear off the area. Again, the eye is pressurized with OVD and I go in with my forceps to continue with the rhexis. As the rhexis moves around in certain quadrants, the liquefied cortex still comes back. Thankfully, the visibility is not greatly affected and I could eventually complete the rhexis quite well. Now, having successfully got through the first challenge, the bigger challenge awaits me. The nucleus is freely mobile, and in such situations, my go-to technique is always the horizontal chop technique. Of course, I use the vertical chop in most of my cases, but these are special scenarios where I'm going to use the horizontal chop technique. The chopper which I'm going to use is a blunt chopper, which is slightly longer. It mimics the classical Chang chopper, which we use for horizontal chop. It's slightly longer and less curved. So the plan is to first get a firm grip on the nucleus, and this grip is possible only when we go in slightly deeper. So I'm going to create a small central pit which is about 3 to 4 millimeter, and then I'm going to bury my phaco tip. So to create the small pit, I'm using the continuous torsional energy, and the nucleus is supported with my second instrument so that it doesn't wobble around, and I can create at least 30% depth of the central pit in the core of the nucleus. I believe that should be enough for me to bury the phaco tip, and let's see how things turn out. Now once the pit is there, I'm going to bury my phaco tip in, and these are my settings for chop mode. I'm going to use only the longitudinal energy. Now bury the tip. The nucleus is slightly pulled anteriorly and towards me so that it gives me space to introduce the chopper around the equator of the nucleus just to hook it, and then the chopper moves towards the phaco tip and then lateral separates. I'm not in a hurry to get a full thickness through and through crack across the entire span of the nucleus. Only the half of the nucleus is split, that is fine. The nucleus is then rotated and I'm getting ready for the second chop. The tip is buried. The chopper goes in and hooks the equator of the nucleus, and then the chopping maneuver is done. The posterior plate is still not cracking. At the same time, the grip on the nucleus also is released. So again, I give a fresh burst of phaco energy, maybe at a little different place, and then continue to do the lateral separation. I must confess that at this point, I was just thinking, what am I doing? Why wouldn't I just do SICs in these cases? Because this nucleus is a tough nut and it was tougher than what I had expected. As the nucleus is being rotated, I realized that the visibility is getting hampered because the conjunctiva is ballooning here. So I come out and give a small nip at the conjunctiva to ensure that further accumulation of fluid in the tenons can be prevented. OVD is replenished into the eye. This is a modified soft shell technique. The dispersive OVD goes in first, followed by HPMC underneath it. The chopping maneuvers are being continued, and again I'm going to use the same technique of horizontal chop. But important point to note here is I'm not very aggressive in trying to break the posterior plate. If I'm unable to break the posterior plate in a couple of attempts, I just leave it there and move on to my division of the next fragment. We need to remember and acknowledge that these eyes don't have healthy zonules, so everything is very flimsy. So we just can't afford to use the same forces of lateral separation which we do for our routine cases. So this we have to be mindful. Now, as I'm struggling to break the posterior plate, it's important to note the maneuvers which I'm doing here. the nucleus, which is held by the phaco tip, is always pulled up. It is not pressing against the posterior capsule, nor is it pressing against the equator. It's just being held and lifted up marginally as the second instrument is being utilized to separate the posterior plate. During all these stressful maneuvers, I need to acknowledge that the pooling of the fluid is being taken care by my assistant, who is using the suction apparatus to just suck out the fluid. So I don't want another complexity of poor visualization in this already stressful situation. So thankful for the suction apparatus and my assistant who is helping me out. So need to be aware that gentleness and perseverance, both the combination, are extremely important. So eventually you can see that I could tease and somehow manage to break the posterior plate and separate this fragment. I'm in no hurry to emulsify this fragment. I just want to protect the endothelium. I come out, push in OVD again, the modified soft shell technique. I begin my process of horizontal chopping of the remaining heminucleus. The important point which I would like to highlight is, once I get a good hold of the nucleus, it's always pulled towards me so that I can visualize the equator of the nucleus as the chopper is being hooked. So basically, I'm insisting that I want to directly see what the chopper is hooking. So this is one way of ensuring that I'm not engaging the capsular bag during the chopping maneuver. So now we have 3 smaller fragments of this heminucleus. The settings are changed to the quadrantimal mode and I'm emulsifying them. Care is to be taken that I don't want emulsification in the anterior plane, neither do I want a lens chatter. So I'm just going slow with my phaco energy delivery to ensure that the turbulence and the chatter is minimized, and also I'm trying to work around at the level of the pupillary margin itself. So this ensures that I'm fair distance away from the corneal endothelium. Please note that my second instrument is always held above the level of the phaco tip, just to ensure that none of the fragments jump around and come into the antechamber. Because the pupil is slightly smaller, we can appreciate that the level of emulsification. So it is happening at the level of the pupillary margin. Now this is the best principle to follow to minimize endothelial trauma and to have a clearer corneas on the first post-op day. The last piece is taken care of, and unfortunately I'm seeing a central plaque which is just at the visual axis. Well, on hindsight, it could have been easily be left there intact and I could have yagged it immediately post-op. There's not an issue at all. Somehow I felt that it was not very difficult to remove this plaque, so I go in with my microforceps and I'm trying to peel the plaque. In this process, I thought I also created a small central posterior capsulorhexis. It looks perfect. What I didn't realize that it had a weak edge at this point, which was not very clearly visible, which was hidden by the presence of this plaque here. And that was an error of judgment. Well, I believed that this tear, because it was quite circular, I thought it wouldn't extend because I had overlooked one weak area. And the planned multi-piece lens is being implanted into the bag. And as the lens is being dialed in, I can see that the posterior capsule tear is enlarged. So now we have a key-shaped opening in the posterior capsule, but mind you, it is not still extended up to the equator. Time to remove the OVD. The OVD which is in front of the lens is irrigated out. I'm avoiding to go behind the lens with my irrigation cannula, which I typically do in most case scenarios, for the obvious reason that the posterior capsule is open. Once the OVD is removed, with the irrigation handpiece still on, I'm trying to examine the extent of the posterior capsule tear. As I can see, it's just ending before the equator. It's a closed tear. But the issue I'm finding is the haptic of the lens is directly in the meridian of the posterior capsule tear, and it is in firing zone. So in the eventuality of the tear extending towards the equator, the haptic can get stuck in the tear and sometimes can cause decentration. So that's the reason I'm uncomfortable to keep the haptic here. With the irrigation handpiece still on, I would be trying to rotate the haptic away from this tear. And as expected, the small amount of PC which had not extended up to the equator is lost, and we have an posterior capsular tear which is extended all the way up to the equator in this quadrant. But nevertheless, both the haptics are away from the posterior capsular tear, and it looks to be pretty stable. Now, before winding up, I would still want to go ahead and confirm the absence of vitreous. I'm using diluted triamcinolone acetate into the antechamber, and thankfully, there's no evidence of any vitreous. We can see the triamcinolone acetate has gone through the posterior capsule and into the burger space. With the irrigation still on, the side ports are hydrated so that we don't lose the chamber. The chamber looks to be stable now. The irrigation handpiece is removed, and the second side port is also hydrated. Intracameral antibiotics are placed into the eye. That's it, the case is done. These are the first day post-op pictures, and the patient was very happy with the visual outcome. So what did we learn from this case? Well, as I keep telling, it's not over until it is truly over. So the nucleus management was very excellent and gentle and planned. If I had a second chance, I could have avoided the peeling of the plaque. Next time, even if I do the plaque peeling, I would like to ensure that the posterior capsulorhexis is well and truly complete before implanting the lens, because implanting the lens itself is going to enlarge the tear if it is not continuous. So that was it. Thank you for watching, and hope you found this helpful.